So, Lauren, I'm thinking we should start with you. Congratulations on the Ravens' victory. I know you sort of split time in your loyalty between the Eagles and the Ravens, but since you live in Baltimore, I'm sure the Charm City is just absolutely nuts right now.
Oh yeah, everyone's looking forward to having Taylor Swift visit potentially this weekend, probably staying, I think the rumor is at the Four Seasons, so maybe hopefully I'll catch a glimpse, but we'll see.
Yeah, so for those of you who don't know, we're recording right before the championship game. So if the Ravens win, they'll be in the Super Bowl and play the winner of the 49ers and the Lions. And if they don't win, then it'll be the Chiefs, and we'll have more Taylor mania for the Super Bowl. So why don't we, David, with that as sort of prelim, I was thinking what we could do is organize this podcast in four quarters and sort of talk about what's happened, what is happening, what will or what is likely to happen, and then what might not happen. So unfortunately, the fourth quarter could be disappointing, kind of like it was for the Buffalo Bills last week. So how does that sound, David?
That sounds fine. I'm not going to hide from our listeners the fact that the two of you know much more about football than I do. So if I make any particular snafus, you'll have to forgive me. But I did know at least that Taylor Swift was dating one of the players from the Kansas City Chiefs, right?
That is correct. So you
Yeah.
you get a gold star for today. So, well, why don't we jump in so we don't spend too much time on football, and I know for the U.S. audience, football as opposed to soccer. So what has happened?
Okay, so what has happened first and foremost is we avoided a government shutdown, and we've talked about this, and everyone had watched it, and it's been very interesting because the deal that was cut back last year cost Kevin McCarthy, the former Speaker of the House, his job, and now the new Speaker, Mike Johnson from Louisiana, has also managed to do this, but without having riled up everybody. So what they did was we were on course for a possible shutdown at the beginning of February, and what they did was they extended that with one extension till March for one, and the rest of the agency's fundings until March 8th. That was a very large vote in the House and in the Senate to do this. So the House margin was 314 to 108, and the Senate margin was 77 to 18. So this was an important step for those of us in Washington. Government shutdowns just are not what we consider to be a good thing. So to be able to do this the idea is that this would get them the ability to do the rest of the um, this would give them the chance to do the rest of the appropriations bills to complete this fiscal year, which you always like to point out. We're still actually dealing with 2024, right?
Yeah, so it sounds like they funded the government through kind of the first 6 months, and then they would use the appropriations process for the second 6 months. And if I'm reading this correctly, and please tell me if I'm wrong, it seems like it's pretty much a political calculation. So both parties are saying it's an election year, shutting down the government's bad for the party in power. In the House, that's the Republicans. In the Senate, that's the Democrats. Obviously, in the White House, that's the Democrats. So if they're able to kind of keep things moving forward through the end of the fiscal year, then they can start focusing more on both the midterm election, or they could focus both on, all the members of the House are up for reelection, a third of the Senate, about a third of the governors, and of course the president. So there's a lot happening this year from a political perspective.
Yeah, and as we're all concerned and our listeners are concerned, hopefully you have the time to do actually what needs to be done in the appropriations that impact healthcare, and also even maybe get around to the fix for doctors and physicians reimbursement for Medicare. So there's a lot there that needs to get done. So avoiding the shutdown is definitely what I would say is a positive.
Yeah, so maybe moving to the second quarter and just really quickly, what is happening? So you mentioned a couple of legislative conversations that are happening, particularly the quote unquote fix for the cut in physician payment. Are there other things happening from a legislative or regulatory perspective that you wanted to highlight?
Well, there's a big regulatory step that just happened, and it's in the process of being implemented. It took over a year to do, which is last year, CMS, the Centers for Medicare and Medicaid Services, issued a proposed rule that had to deal with prior authorizations and requirements, particularly in Medicare Advantage. And there's been a lot of discussion about Medicare Advantage and about the use of prior authorizations, and how difficult it's become for many patients and their care teams. And so this was something that was really we had very much supported. I think it's really interesting because in the years since it was proposed, there's a lot of talk about actually even going further than what this final rule did. The final rule, first of all, basically did some things that brought Medicare Advantage into what the government has required everyone else to do. So what it did was it brought them into the requirements about using APIs, they're like built into your various apps on your phone, building into the APIs all the required updated interoperability software that the government requires, so that Medicare Advantage would be able to provide this information and these prior auths very clearly, very succinctly, without electronic interference. What they did was they said Medicare Advantage must respond to an emergency request within 72 hours, so that's 3 days, and a general medical request that is not emergency, they would have up to 7 days to issue the prior authorization or not. And so to get it resolved. It's very interesting because Capitol Hill has become involved, and there's been a lot of discussion. There's a bill that's been talked about on the Hill that actually does even more than that. It actually would say the emergency has to be done in 24 hours and that the general medical should be done in 72 hours. So I think even while we supported this being happening, I think many of us in the healthcare and kidney care space are thinking we're going to have to go back and have a conversation about actually even bumping this up higher.
So you mentioned Medicare Advantage. I guess I know we've talked about this before, but this is increasingly becoming a challenge just across healthcare. And I'm just wondering, specifically for people with kidney diseases, particularly those with kidney failure on dialysis, what does this all mean?
Well, it means a lot of things, because for up until 2021, people who had kidney failure in particular, not kidney disease in general, but once you had reached the ESRD stage or kidney failure stage or ESKD, as I've said on here before, we still call it ESRD because that's what the federal government, that's the actual statutory designation for the Medicare program. So it's now at a point where over half of all of the Medicare beneficiaries are in Medicare Advantage as opposed to fee-for-service. And it looks like we're either at half or close to it on just the ESRD patients, the kidney failure patients. So that has a big impact on a lot of things that our people are interested in. First of all, it is impacted, and we'll get to it. We'll talk about it. It gets to whether the data that has always flowed into USRDS, the United States Renal Disease Service, USRDS. Why am I forgetting what the D is?
Data.
But yes, U.S. Renal Data Services Systems. It's always flowed into that, and that's a really important part. But since Medicare Advantage has started, there was not clarity on whether it was going to flow into USRDS or not. It has started to now. It is also, unfortunately, running a year behind what the Medicare regular data is. So that's a little bit of a problem. So, but just in general, there's been a lot of things that people have gone into Medicare Advantage for, and not found themselves completely happy with it. So we are beginning to see some people come back to fee-for-service within Medicare. And that's the complicated landmine that is the data from Medicare Advantage is really complicated. And we would take us a couple hours to go over. But the other thing is most of the quality metrics that impact dialysis facilities and the payments for innovation in those spaces has not been replicated in the Medicare Advantage contracts. So what we've worked for such a long time is now only covering half of those patients.
So, David, congratulations. You got us to halftime. You used your timeouts better than the Rams head coach, Sean McVay. That's an inside joke for Lauren and me. And why don't we move into the third quarter where we're going to focus on what will happen. So as you think about the near future, in addition to the discussions around the appropriations, hopefully addressing the physician payment cut. What else do you think will happen in the near term?
Well, the two mentioned that you just mentioned are really important. Yes, that they do the appropriations and that they address the physician cut, Capitol Hill. That's really important, and we're hoping that will happen. But we have two other things that we are expecting, and they are on their way. One of them is a transplant model that's done by the Innovation Center at CMS. And they have a transplant model that ASN and many of us have been contributing to in discussions for 2.5 to 3 years actually now. And it's supposed to be post-transplant longitudinal care. And exactly what's going to be in there, we don't know. We've discussed many things with the Innovation Center, and we'll see. But in this process, once they develop it, they send it to the Office of Management and Budget, which is kind of the White House gatekeeper to anything the government wants to do. And it looks at all the dollars and says yes and no. And so they are currently reviewing it. When they're through reviewing it, and they will send it back to CMMI, which is the Innovation Center at CMS. And then they will have to adjust it, and then it'll come out for comment. And that is, comment would be assuming that it is a mandatory model. If it's a voluntary model, there won't be comment.
So David, before you move to the next issue, I just, I want to ask an awkward question, which is, given the challenges we've had with the current voluntary and mandatory models in the kidney care arena, why does there seem to be so much positivity around a transplant model?
Well, it kind of goes to the next point that I'm going to get to, and I'll get to in a second, which is we have dealt with transplant a lot on the surface that really has to do with the collection of organs, and the way in which that they are handled. What we haven't really dealt with is whether the payment structures are such to really provide the support that is needed for the entire kidney team when a kidney transplant occurs. And I think there's a lot that they have been learning, and a lot that, some of it they didn't get right in the first model. So I will say that. And they're beginning to learn that and see that. And so, a perfect example is they're learning that maybe you got to follow the patient and its transplant continuously, regardless of where they stay in Medicare. So what I mean by that is, in the current models, if you get a transplant and that it gives credit to the nephrologist and to the transplant center, the problem is that after a year or 2 years, let's say I have had a transplant and I decide to go to Medicare Advantage, I basically disappear from the books of the people who are getting credit for having gotten a transplant, gotten me to a transplant. So in the model, so they're beginning to understand very clearly you can't do that. You're taking away the incentive for really trying to move everyone along into transplant. That's really overly simplistic, but it does go to the next one. Is that okay?
Yeah. No, that's helpful. I think that the issue is just, and we knew this going in, and we continue to learn it, which is, this is not a situation where CMS they issue the proposed rule, we comment, they issue the final rule, it goes into effect. But then there's constant interaction, both through the regulatory process or just picking up the phone and calling the people responsible, in this case at CMMI, to say, hey, we've identified these challenges, we really need to work on them. And then ideally that thing gets in the proposed rule or it gets implemented, et cetera. So it's an iterative process. And I think what's really important is for people to recognize that we think a lot about advocacy on Capitol Hill. We think less about advocacy at the regulatory agencies, if that's CMS, CMMI, even OMB, but you have to be present and active and articulate in each of those different forums.
Yes. And we are encouraging them through rulemaking this summer to actually make some of the changes in that, and particularly in the mandatory model that is currently in existence, and such as the one that I was just describing. So we are moving there along.
Okay, so we're at the end of the third quarter. There's one other piece of information you'd like to share with us, and then we'll go to the fourth quarter quickly.
Sure. This has to do with OPOs, which are organ procurement organizations, and basically CMS is working on a new rule on OPOs, and We had a rule on opioids 4 or 5 years ago, and it did make some adjustments. It did impact a lot of procedures and a lot of operations from opioids. Now there is a need to go back further. We've talked about it repeatedly, that there has been an organ procurement network modernization initiative, organ procurement transplant network modernization initiative ongoing to really move transplant along on a couple different levels. This proposed rule is supposed to address some of the things that need to happen to further move transplant along, to really kind of bring the opioids to a certain level of performance that the government thinks that would be beneficial for everybody.
David, congratulations. We're now into the fourth quarter. By my scoring, you're up 24-17. So you're doing well. What do you think is not going to happen? So what should we be perhaps anticipate as a challenge?
Well, one of the things that I think is a challenge, and we're trying to see, is there has been a movement quite some time. There was a designation that by 2025, phosphate binders would be incorporated into the bundle, and therefore they would be administered by dialysis facilities with patients there. There's always been concern in the kidney community about this move, and whether it was an appropriate move, and whether or not there were resources to appropriately handle that, since dialysis facilities are not pharmacies, and there's a lot there. So this has been delayed before, and it's been delayed until 2025. This year, and CMS seems determined to move forward with this. This year, there is an effort on Capitol Hill to add a year extension to 2026 for there to be more development of evidence to make a final decision on whether this is the right way to go or not. So that may happen, that may not happen. So whether or not phosphate binders are in the bundle in 2025 is kind of remains to be seen.
So before I ask Lauren if she has questions about any of these issues, I can't help but ask the kind of elephant in the room question, which is, at what point does the community say that the bundle perhaps has not been successful, and that the people with kidney failure on dialysis in the United States would be better served without the bundle?
I think that the way we're going to need to move forward is that this particular period of experimentation with the bundle has left us with a lot of understandings of what is really at stake, and it really has been, I think most people would agree, very harmful for innovation, and it is very problematic with no new dollars ever going into it. So I think that that's exactly what it is that if this continues on as a budget neutral, no new dollar situation, then I think it's really just the community has to say this can't go on like this anymore. And we need to really address whether or not, if you are going to bundle, when you put in new dollars and how Congress allows that to happen, and tries to really kind of get up to speed with what the way the economy works elsewhere. It's trying to enforce something that doesn't really work everywhere in our economy.
Well, thanks. Lauren, any questions for David or me before we close out the game? We're in the 2-minute warning right now.
Oh, no, I think we're ready to move into that 2-minute warning. Curious to see how this game ends.
David is always optimistic. I am always pessimistic, or maybe it's the reverse. It's hard to say at this point. But thanks, Lauren. Thanks, David. Really enjoyed the discussion.
Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition, or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.